Thank you. Thank you, and good afternoon from India, Professor Pinto, and Professor Pan, and team TMA, and all the delegates who are present here today. My job is to present a real-life case in front of you, particularly highlighting the stepwise diagnostic approach to a case of angina, and maybe a little bit of management issues, which is invariably intermingled with diagnostic steps. So I'll go to the next slide. Yes, I have got before you a 48 years old lady who is an executive, hypertensive and dyslipidemic for the last 5 years. But she is non-diabetic. She stopped smoking for last 2 years after a 20-pack years of smoking history. Her father died of heart attack before 70 years of age. She presented with chronic coronary syndrome, class 2, for last 2 years, relatively unchanged in its intensity. But there was a recent increase of pain during a mountain trekking, which was transient and now settled after she came down to the plain. She is on, for the last couple of years, on bisoprolol 5 milligram daily, amlodipine 5 milligram daily, atorvastatin 20 milligram daily, aspirin 75 milligram daily, and she was given nitrate to be used under tongue as and when required, which she used during the trekking trip when she had got some more angina than her usual. Now, when she came to us, to me, I found her, she is a relatively well-preserved lady with no general survey abnormality. Her BMI was 26 kg per square meter. Pulse was 68 and regular. She is on beta blocker, bisoprolol 5 milligram. Her blood pressure is 138 by 76 millimeter mercury. Maybe well controlled, but not maybe in today's standard. We want 130 by 80 or below. Her other systematic examination like cardiovascular, chest and abdominal examination were more or less unremarkable. There's mild pitting ankle edema. I thought it was due to amlodipine. Her JVP was not raised. So obviously, as she came in a stable condition, we had no rush to push for anything. We wanted to have a full picture of the lady. So I did some basic investigations. Her full blood count was normal. Her sodium, potassium, and urea creatinine were normal. Liver function, thyroid function were unremarkable. Fasting sugar was 88 milligram and HbA1c 5.8%. Total cholesterol 170. By millimole, it will be about 4.2 millimole per liter. TG is 160. LDL is 90, which comes to about 2.2 millimole per liter. HDL is 46. Urine routine was normal. And of course, on the baseline, we do some cardiological investigation because she is a case of angina, very, very good history of angina. So we did a resting electrocardiogram, which showed the patient was in sinus rhythm, a bit of tachycardia at that time, maybe due to anxiety of the ECG procedure, with left ventricular hypertrophy, a bit borderline hypertrophy. Echocardiogram corroborated the concentric mild left ventricular hypertrophy. There was also grade 1 left ventricular diastolic dysfunction. There was no regional wall motion abnormality. Valves were okay. And her ejection fraction was around 70%, 68 to 70%. Her chest X-ray showed increased cardiothoracic ratio. Her ultrasonography showed grade 1 fatty liver. Otherwise, it was normal. So we thought, which was more commonly available in my part of the country, is a treadmill test. So I thought to prognosticate the patient, because there is no doubt in my mind that we are tackling a case of chronic coronary syndrome, or at least the patient is having angina, which is stable at the moment. So just for prognostication and get further information, we did a treadmill test, which came positive actually with 2 millimeter horizontal ST depression, as you can see in the precordial lead of V3 to V5 in stage 2. Along with there was reproducible chest pain, And there was some delayed recovery. It took up to 2 to 3 minutes after stopping the treadmill to get the ST segment back to normal. Though we know that in ladies, perhaps treadmill test is not that sensitive or specific, but when it was positive, along with the chest pain, along with delayed recovery, along with the background history of chronic coronary syndrome, I took it seriously, and I thought the lady required further evaluation. We increased the medicine for the time being because she had the recent episode of angina while trekking on her beta blocker, calcium channel blocker, statin, and aspirin. So I added a long-acting isosorbide mononitrate. You may ask why. I just went by the latest European guideline, but of course we can discuss that. I gave an isosorbide mononitrate long-acting, 60 milligram per day. Atorvastatin I increased because I was not happy with an LDL cholesterol of 78. I wanted now, it is an atherosclerotic cardiovascular disease. It is the highest risk, so my target is 55 milligram of LDL cholesterol. So I increased the atorvastatin to 40, and I advised coronary angiogram. Now you might ask why, because I thought that we need a clearer picture of this lady, because she had symptom while trekking. She will go on trekking again. And during a treadmill test, she had the ST depression quite significant with delayed recovery. So whether we are dealing with a case of triple vessel disease, whether we are dealing with a case of left main disease, I thought it's better to have an idea. I could have done a CT coronary angiogram, which is not so easily available in my part of the country. But I thought, I discussed with the lady, and she thought we'll go for the definitive test. And she actually agreed for a coronary angiogram. I had other thoughts in mind as well. I'll tell you later why I insisted on the invasive coronary angiogram. And here I saw some borderline lesions in the LAD, around 40-50% in where the first septal is originating. And same happened in the proximal part of right coronary and distal part of right coronary. But in both the situation, as they were borderline, I did an FFR, and both the FFR were negative. One, the LAD FFR came 0.87, and the RCA FFR, it looked a bit more significant, around 60% lesion by eyeballing and by computer analysis. The FFR came about 0.82. So both the cases were hemodynamically so-called non-significant. So the questions arise at this point. Now I sat down with the lady after all this information in my hand, and certain questions came into my mind, not for the first time, of course, but relevant to this case. We know that FFR detects ischemia, but does the amount of ischemia always correlate with pain? When you are talking about angina, Canadian cardiovascular classification stage 1, 2, 3, 4, does a particular lesion can tell that it will cause class 3 pain, this will cause class 2 pain? Because pain is subjective. We'll discuss that, of course, with Professor Pinto's expertise. We'll discuss. Pain is very subjective. Some people suppress pain. They think it's a shame to discuss about pain. And some people exaggerate pain. So I do not know whether a particular lesion and the ischemic pain can be corroborated. That is number one dilemma in my mind. The second was, pain is a subjective feeling, of course, dependent on so many factors, on a particular patient, his socioeconomic background. So even with the same amount of ischemia, I'm first raising the question whether a particular ischemia is correlated with a particular amount of pain. And the second question comes, whether a particular amount of pain is related to the particular ischemia or patient's other background. And thirdly, does the FFR truly reproduce a physiological condition? Say, while the patient was trekking, she had angina. While she was doing treadmill test, she had angina, but her FFR is negative. Can they coexist? Or there is some problem in my assessment? Or they can really happen in real life? Is FFR a foolproof test of ischemia? Next, a question comes, is there vasospasm? Particularly, we know that vasospasm is related with borderline lesions. 30%, 40% plaque disease usually can be associated with vasospasm in the lesion related. And actually, this lady also gave history sometimes early morning chest pain when she just starts her day. So is it a vasospastic element also playing a part in this lady? And is microvascular disease causing the angina? She is a middle-aged lady. Her coronary angiogram is not so dramatic. She's having typical angina. She is having treadmill test positive. So are we dealing with a case of microvascular angina, at least contributing partly to her symptom? May not explain the whole symptom, but is it contributing to the symptom? The next slide, let me move. Oh, sorry. Now, so with these disturbing questions in mind, I didn't insist the patient to go for further things. She had gone enough. She had gone through all the tests and an invasive angiogram. She had spent money out of her pocket. So I thought, let's do something about the lady. So what I did and why I did, I'll tell you in a minute. I changed the beta blocker to diltiazem. Instead of 5 milligram bisoprolol, I changed it to 90 milligram per daily diltiazem in divided doses, because I thought there could be a vasospastic element where perhaps diltiazem will be better than a beta blocker. Though I could not demonstrate any ST elevation during the pain, not a pringemetal angina, I could demonstrate. But what is the harm in changing the beta blocker to diltiazem, number one, particularly when the ejection fraction is normal, no contraindication for diltiazem. So I did that. And secondly, I add a metabolic agent, trimetazidine long-acting. It's now available in India, 80 milligram per day. I thought if there is a microvascular angina component, I really cannot prove or disprove it at this moment in my setup. So why don't I try a metabolic agent and see what is the effect on the lady? Actually, the result was very gratifying. For the last 6 months, the patient did not have any angina. She went to a short trekking trip, not a very long, very big one, but a short trekking trip, which was uneventful. And her hemodynamics and her biochemical parameters, they actually improved. Her blood pressure improved, her blood cholesterol improved, and she is a much more good shape as far as guideline-directed medical therapy. So now, my friend, I go back to Professor Pinto for discussion on this particular issue.
Thank you so much, Dr. Ray. It was really a very, very nice case and a very good example of what we are trying to discuss here on the management of patients with angina and with coronary disease. It's a very, I would say, very interesting and challenging case, 48-year-old lady with some risk factors with typical angina. And the whole sequence of what you've done in terms of diagnostic, of course, we will discuss a little bit, but in terms of diagnostic procedures, and then the therapeutic changes that you've done that go very much into accordance with what is the current management. But that's exactly what we are discussing here. So my first question to you is actually on the use of the treadmill test. As you know, there's been some discussion on the role of treadmill testing particularly in the setting of patients with chronic angina or with chronic coronary syndromes. I know it changes a little bit the practice in different parts of the world, also depending on having more access to other types of diagnostic methods. And in the guidelines that is actually shown, and it's written the use of the treadmill test, which is a little bit downgraded in these guidelines when compared, for instance, with CT angio, which now is more available in some places. I know in others it's still complicated. But my question to you, in a patient with the typical angina and the patient with risk factors, what is the main, in your experience, what is the main purpose of the use of a treadmill test? Is it to make more secure in terms of diagnosis, for risk stratification? Should this patient go, if you have a high suspicion of coronary disease, should you take them directly to the cath lab and do coronary angiogram? What is your view on this, and also on the use of other methods such as the CT angio?
Yes, sir. Yes, sir. You are absolutely right. As I mentioned, I was absolutely sure about the diagnosis of angina and ischemic heart disease. So nothing else was required to diagnose angina and ischemic heart disease. As you mentioned, I thought I would do some risk stratification on this lady because there is no rush, there is no acute coronary syndrome. So I'd rather do the risk stratification to intensify my treatment and decide my my molecules to use. So I had got three options: the stress echocardiogram, the MPA, the radionuclide study, or the TMT. It all depends on the expertise I get, the money involved, and the dependence I have on the result. You know that stress echocardiogram is very subjective, and I find it quite unsatisfactory in my part of the world to get a good result of stress echocardiogram, particularly in a lady where sometimes the her BMI was slightly on the higher side, and she's a little hefty side. So I thought there could be some window problem, particularly when the heart rate is high. So I thought that is not an option. The MPA is not very common in my part of the country, and it is very expensive, and it takes a whole day. And I thought, let's do a treadmill test. If it is negative, it is or very mildly positive, I would raise the case over there and you just treat the lady for chronic coronary syndrome. But if it is somewhat moderate or strongly positive, I'll take it further just to see whether I'm missing some critical lesion or some left main or triple vessel disease. So that was the idea, and it is very easily available. It's cheap. Any patient can do it. So I did it, and as you saw, it was quite emphatically positive, I would say. I know there is still 30% false positive, false negative result, but I thought with the background, I was quite happy that I got a treadmill test, which was rather confirming that this lady is having some kind of serious problem, maybe. So that's what I did, the TMT, Professor Pinto.
Very good. And did you repeat it after the treatment that you've done and the very good clinical result? Do you repeat it just to check if there was a change in the response to exercise?
I actually did not mention it. In the last 6 months, after the patient was stable for 3 to 4 months, I asked the patient to go for a repeat treadmill test, and there was remarkable change. There was very remarkable change. It was negative. She could do about 8 to 9 minutes when she could do only 6 minutes last time. She could do 9 minutes. There was no STT changes. There was no chest pain. And the patient felt that I am feeling the difference now, doctor, that which was done 4 months ago and now it is done. I'm feeling much fitter today. So that was perhaps gratifying.
Yeah, that's very good. That's actually one of, from a clinical standpoint, we do that quite in this type of cases. So to monitor what is the response in terms of ischemia to exercise, to the treatment that has been done and quite successful as you've shown. Now, another question to you still regarding, we are focusing a little bit on diagnosis today, although we're also going to be talking about treatment. But what is your experience on doing some vasoconstriction challenges in the cath lab, like for instance, using acetylcholine or ergonovin? What do you have that sort of experience in terms of if you suspect? In this case, we had some lesions, although they were a little bit borderline, and you showed with FFR that they were not apparently significant. But do you do challenge to provoke vasoconstriction? Do you think that's useful?
Argonovin, I have got no experience, Professor. I didn't use argonovin ever. But acetylcholine I used in a few cases. I got a kind of mixed result with acetylcholine, Sometimes they are quite reproducible. Sometimes I get because you can only give it once, you cannot repeat it. And I sometimes is not very happy what is happening, and I could not interpret the result very nicely all the time. So I personally am not a very big fan of doing acetylcholine challenge all the time. What is your view, sir?
We do in selected cases. So it used to be very popular some years ago, but now also with FFR and the hemodynamic assessment in cath lab that we can do on one hand. On the other hand, at the end, the management of these patients, at least medically, it's what you've just done, and that was actually my question to you. If you've done, in my view, quite correctly to change a beta blocker to a calcium channel blocker such as diltiazem, because you certainly suspected of having some vasospasm here, and also including a metabolic agent, in this case, trimetazidine, which combines the two main mechanisms of action here. On one hand, you are tackling with a vasoactive agent such as diltiazem. On the other hand, you are using the metabolic agent. So there's some complementarity here, and I think that's quite correct. My question to you is, why didn't you do it earlier? Meaning, you waited for the result of the coronary angiography to take this decision. You also, on the first step, you introduced actually long-acting nitrates. The question to you is, do you think you could have done this one step before, or that's exactly what you had to sustain your decision, the fact that with the coronary angiogram you feel more comfortable in changing that treatment?
Yes, it's a very, very relevant thing. What actually was in my mind after seeing the treadmill test, that whether I'm missing some critical lesion, particularly the left main or a triple vessel or a proximal LAD critical lesion, that was in my mind. So I thought, without experimenting with medicine at this stage and seeing whether the patient is doing well, patient might get better for some time, then suddenly she can have a event. So I thought I'd rather fix the anatomy first, what is there, and then only I have got all the options. I was not also sure whether there is a vasospastic element, because if I got an 80-90% lesion with FFR negative, FFR positive, then perhaps beta blocker was the perfect choice anyway. So I did not go on changing the medicine unless at this critical juncture, unless I see the anatomy of the coronary. But once the anatomy is in front of me, I did those changes. I thought you think that those were the justified changes I made, isn't it?
No, I totally agree with you, and I think that was the right thing to do. Okay, well, we will still have some time at the end for discussion, so please join us for the second case, and then for the discussion at the end. Thank you so much, Dr. Ray. It was really exciting to discuss this with you, and congratulations for your case.